the classification of the univentricular heart, how the natural history goes for univentricular physiology, the clinical features, and how the surgery evolved over a period of time in case of single ventricle. Congenital cardiac anomalies. Some hearts lacks two well-developed ventricles, making them difficult to manage medically and surgically.
Same slide.
Slide didn't move. Yeah.
Okay, right.
So some hearts lack two well-developed ventricles, making them difficult to manage medically and surgically. Single ventricle is a rare congenital heart defect which constitute just over 1% of the congenital cardiovascular diseases. The single functional ventricle could be morphologically right or left, with the second ventricle usually hypoplastic or insufficiently functional. For a developed ventricle, the key features are inlet portion, which supports the subvalvular tensor apparatus, the trabecular zone, and outlet portion, which leads to great arteries. Incomplete ventricle. Often, a second ventricle exists but lacks an atrioventricular connection. The circulatory physiology. Normal hearts have series circulation, that is, systemic and pulmonary circulation comes in a sequence, while functionally univentricular hearts have parallel circulation, which leads to poor oxygenation and severe physiological consequences. In neonates with single ventricle, the systemic and pulmonary blood flow mix with each other in the single functioning ventricle, with consequent lower systemic oxygen saturation, which usually between 75 to 85%. The single ventricle then provides both the systemic and pulmonary blood flow. Little bit about the history. In 1824, In 1824, Andrew Fernando Holmes published autopsy observation on a 21-year-old man who died with chronic sinuses and congestive heart failure. It is also called in his name as Holmes heart. In Holmes heart, aorta, which originated from morphologic left ventricle, while the pulmonary trunk originated from the outlet chamber, a separate chamber. Next come in 1858, Thomas Peacock described heart in which the auricular sinuses are separated by a more or less complete septum, and there are generally two auriculoventricular aperture, while the ventricle is either wholly undivided or presents only a very rudimentary septum. Complete mixing of the pulmonary venous and systemic venous blood occurs at the atrial or ventricular level, and the ventricle then distributes this output to both the systemic and pulmonary beds. In the case of a single anatomic ventricle, there is always obstruction to either pulmonary or systemic blood flow as the result of complete or near complete obstruction to inflow and or outflow from a hypoplastic ventricle. The embryologic cause is not fully understood. It probably results from limitation of either left ventricular inflow or outflow, such as development of severe AS in very early stage. Other factor contributes like decreased antegrade flow through left ventricle. Most common cause of this is mitral atresia. A decreased division of the cardiac myocytes observed in all cases. Some facts about the genetics. Familial inheritance. It is usually autosomal recessive, and multifactorial inheritance have both been postulated. Sibling recurrence risk is 0.5%, while sibling recurrence for all other cardiac malformation in univentricular heart is 2.2%. Definable genetic disorders is 28% of cases, while most common are Turner syndrome, Noonan syndrome, trisomy 13, 18, 21, or other microdeletion syndrome. In 2000, the consensus classification by the Society of Thoracic Surgeon, International Congenital Heart Surgery Nomenclature and Database project, they included the functionally univentricular hearts into the following subtypes. First is double inlet atrioventricular connection. It is further divided into double inlet left ventricle, double inlet right ventricle. Second is absence of one atrioventricular connection, which further subdivided into either right-sided tricuspid atresia or mitral atresia. Third one is common atrioventricular valve with one well-developed ventricle. Unbalanced common atrioventricular canal defect comes into this category. The other categories are heterotaxy syndrome with only one fully developed ventricle, or there are some rare forms of univentricular hearts, while the separate one category has been kept for hypoplastic left heart syndrome. So the single ventricle with a functional left ventricle can be either in pulmonary atresia, tricuspid atresia, or double inlet left ventricle, while the functional right ventricle can be hypoplastic, the left side, that is hypoplastic left heart syndrome, double inlet right ventricle. Single ventricle physiology can also exist in the presence of two well-formed anatomic ventricle. In the following cases, there are two well-formed anatomic ventricles, but functionally it is single ventricle physiology. Pathology of failure with pulmonary atresia, where pulmonary blood flow is supplied via a PDA or multiple aortopulmonary collateral arteries. In truncus arteriosus, in severe neonatal aortic stenosis with interrupted aortic arch, in heterotaxy syndrome. This is the schematic diagram of three types of univentricular hearts, where in the first picture there is left ventricle with a double inlet or right ventricle with the double inlet, while the second is truncus arteriosus with transposed either L transposed or D transposed great arteries.
It's not truncus. It looks like tricuspid atresia.
There is a tricuspid atresia with transposed great arteries, either L transposed or D transposed. The third one is unbalanced AVHD with hypoplastic right ventricle in the form of DTGA with a VHD or double outer right ventricle. One of the most common univentricular physiology is DILV, double inlet ventricles. Among its the most common is DILV, double inlet left ventricle. Double inlet ventricles are characterized by both atria and atrioventricular valves emptying into a large ventricle of either left or right ventricular morphology. The vast majority of these DILV, both atrioventricular valves empty into a large ventricle of LV morphology, and there is generally a smaller right ventricular outflow chamber which is located anteriorly. There are three general classes of DILV. Normally related great arteries, 15% cases, while D-transposed great arteries, 20 to 25% cases. L transposed great arteries consist of the most 60 to 65% cases. The patient with DILB and normally related great arteries, which also known as the Holmes heart, has a normal aortic valve and aorta arising from the large left ventricle, with a pulmonary artery arising from a RB outflow chamber with a variable degree of subpulmonary stenosis. The patient with DILB and D-transposed great arteries has the aorta originated from the rightward, the right ventricular outflow chamber, while in L-transposed great arteries, the aorta arises from the leftward RV outflow chamber. DILB with L-transposed great arteries, the single ventricle is an anatomic left ventricle. The great arteries are transposed with the aorta anterior to and left to the pulmonary artery, which arising from the rudimentary right ventricle, which is depicted in the picture aside. The both atrioventricular valves open into a single ventricle, that is double inlet. The opening between the mitral, the main and rudimentary ventricle is a bulboventricular foramen, which is indicated by the thick arrow in the right side. And the stenosis of the pulmonary valve is present about 50% of the cases, which is shown as the thick marks. This type accounts for the most, that is 70 to 75% of the cases of single ventricle. Another most common form of univentricular pathology is hypoplastic left heart syndrome, which usually consists of an underdeveloped left side of the heart. The atresia of the aortic and mitral orifice is encountered. There is hypoplasia of the ascending aorta also might be there. The left ventricular may be small or non-functional or totally atretic. The pulmonary venous return from the LA to RA through a large patent foramen oval or a large ASD. The mixing of the systemic venous blood with the pulmonary venous return is at the level of RA and RV. RV ejects blood into a very large and dilated mean pulmonary artery. Systemic circulation is supplied in a parallel fashion to pulmonary circulation through a duct-dependent circulation through PDA. There may be multiple obstruction to blood flow at different level. There might be aortic valve atresia. There may be aortic arch hypoplasia, which poses the patient to a great risk of systemic flow. Blood flow to the coronary and cerebral circulation is often retrograde, usually little or very small flow through aortic valve. There is always a postnatal decline in pulmonary vascular resistance, which places a systemic and ductal dependent flow to the coronary and cerebral circulation at risk. The risk of hypoperfusion secondary to pulmonary runoff because of Still phenomenon. The pathophysiology of single ventricle. The complete mixing of systemic and pulmonary venous blood at the atrial and or ventricular levels or both. The oxygen delivery is affected by either systemic vascular resistance, pulmonary vascular resistance, which in turn affects on cardiac output. The systemic vascular resistance, when there is excess pulmonary blood flow, there is decreased pulmonary vascular resistance and increased systemic vascular resistance. In these cases, oxygen saturation often more than 85%. There is decreased lung compliance. There is back pressure effects like hepatomegaly. There is ventricular dilatation, and atrioventricular valve regurgitation may produce low cardiac output. While in case of inadequate or less pulmonary blood flow with increased pulmonary vascular resistance and decrease systemic vascular resistance. The oxygen saturation is usually less than 75%. There is presence of cyanosis. There is myocardial hypoxemia, which might in turn produce the low cardiac output. In case of high cardiac output patient, there is high mixed venous oxygen saturation. There is oxygen saturation of arterial oxygen saturation of more than 80%. There is good perfusion without any hepatomegaly, ventricular dilatation, or lactic acidosis. While in case of low patient presented with low cardiac output, there is low mixed venous oxygen saturation. The arterial oxygen saturation is often less than 80%. There is poor peripheral perfusion and there is lactic acidemia. There is complete mixing of the systemic and pulmonary venous blood at the ventricle, and oxygen delivery is affected by all this balance between the SVR, the PVR, and the cardiac output. The optimal oxygen delivery is provided by a balance between these two, which in turn responsible for maintaining the cardiac output. About the calculation of the flow using the Fick's formula, the pulmonary flow, that is denoted by the QP, is the oxygen consumption in the unit of ml per minute divided by the oxygen content in the pulmonary vein minus oxygen content in the pulmonary artery. This oxygen content difference and the oxygen consumption, when we divide the oxygen consumption between the difference in the content, we will get the pulmonary flow, while systemic flow is denoted by the oxygen consumption in ml per minute divided by the oxygen content in aorta and the difference between the aorta and in the mixed venous blood, which is taken from either SBC or from the RA. Then we calculate the PVR, while the PVR denoted by mean pulmonary artery pressure minus the LA pressure, the mean LA pressure divided by the pulmonary blood flow, the formula for resistance. While the systemic vascular resistance, using the same formula, the mean aortic pressure minus the RA pressure, the difference between these two pressure divided by the systemic flow. As a result of the physiology, the ventricular output, which always provides QP plus QS, both pulmonary and systemic flow. The relative pulmonary flow and relative systemic flow is determined by the SVR and TVR, the tissue vascular resistance. While the distribution of systemic and pulmonary blood flow is dependent on the relative resistance to flow, both intra and extracardiac, into the two parallel circuit. Single right ventricle has twice the workload of an in series ventricle, which causes a significant volume overload in case of univentricular heart, because the blood flow is in series sequence. Neonates with functional right ventricle have pulmonary and systemic circulation that are supplied in parallel, creating a significant cyanosis and ventricular volume overload. Oxygen saturation, if we take both from the aorta and the pulmonary artery, is the same because of the mixing. Depending on this pathophysiology, the goal of the palliative surgery in case of univentricular hearts is to convert the single ventricle circulation from a parallel to a series arrangement. The ventricular interdependence doesn't occur unless a right ventricle contributes to the left ventricular function and a left ventricle contributes to the right ventricular function. So, accordingly, the ventricular interdependence, the phenomena, doesn't exist in univentricular hearts. If we take some statistics, about 80 to 90% of the cases, the ventricular chamber that receives the atrioventricular connection is morphologic left ventricle, while in 10 to 25% cases, the ventricular chamber that receives the atrioventricular connection has a right ventricular morphologic feature and incorporates within its mass a rudimentary compartment, that is a left ventricular remnant or trabecular pouch. In less than 10% of cases, the univentricular heart has a indeterminate morphologic features. The natural history of the univentricular hearts is greatly influenced by the degree of the pulmonary blood flow. The second is the systemic outflow tract obstruction, either obstruction at the pulmonary level or aortic level. The anomalies of pulmonary or systemic venous return, and lastly, the associated lesion, if such like coarctation of the aorta. Severe obstruction to the pulmonary blood flow at birth is an important determinant for early death in univentricular hearts. Patients with unobstructed pulmonary flow can develop congestive heart failure symptoms in infancy only, or if unoperated, they may later develop the sequential pulmonary vascular disease. The clinical course may be worsened by the presence of associated left-sided obstructive lesion, as already told, that like coarctation of aorta. A small subset of the patient, the pulmonary and systemic circulation are well balanced because of unrestricted systemic blood flow and sufficient pulmonary obstruction to control the pulmonary blood flow. These patients have a more favorable outcome. The aim of the surgical intervention is to improve the natural history by balancing blood flow between the pulmonary and systemic circulation and ultimately separating this circulation. If the natural history is difficult to assess truly after 1950s because of the increased rate of surgical intervention. Early surgical intervention, that is the palliative measures like aortopulmonary shunt or pulmonary artery bending, has significantly improved the survival of these patients. Some studies shows that in case of unoperated patients, studies like Moody et al., there is 50% mortality by 14 years. The most common cause of death is congestive heart failure, 20%, 20% is arrhythmia, and 10% is unidentified. While in Franklin et al., the patient with single ventricle has either got a partial repair or there is no complete repair. There, in that study, it was shown that 1 year survival rate is 57%, 5 year survival is 43%, while 10 year survival is 42%. In the clinical features, the clinical manifestation hinge on the presence or absence of pulmonary outflow obstruction. Patients with restricted pulmonary blood flow may exhibit cyanosis of varying degree. Some may have drug-dependent pulmonary circulation and will become rapidly cyanosed as the ductus arteriosus closes after birth. Without pulmonary stenosis, infants with low pulmonary resistance, low PVR, presents with signs and symptoms of typical large left to right shunting, that is congestive heart failure and failure to thrive. Symptoms will deteriorate with the falling pulmonary resistance over the period of time. In the specifically in the first, even after the first few weeks after birth. An underdeveloped child, a diaphoretic child, mildly cyanotic tachypneic infant is expected appearance associated with the increased pulmonary blood flow features and congestive heart failure. Usually, this is the physical appearance of a child with univentricular physiology. There may be profound cyanosis also, which is expected appearance with severe pulmonary stenosis or atresia. When pulmonary blood flow is increased, the impulse of the volume overloaded single left ventricle is hyperdynamic. A visible and palpable systolic impulse in the third left intercostal space is a result of leftward and anterior position of an inverted outlet chamber. The second heart sound is usually loud and palpable because aorta is anterior, whether the outlet chamber is inverted or non-inverted. A systolic thrill also may be palpable at the mid-left sternal border, which is an evidence of subaortic stenosis caused by the restrictive outlet foramen. In radiological findings, in X-ray, the location of the outlet chamber is a key diagnostic feature in the X-ray. An inverted outlet chamber forms a localized convexity at the upper left cardiac borders and gives rise to an aorta that is convex to the left or rises vertically as in congenitally corrected TGA. X-ray, this right side, it is shown an X-ray of from a 24 years old man with single morphologic left ventricle with pulmonary vascular disease in advanced stage. While an inverted outlet chamber forms a convex bulge at the left upper cardiac border, which gives rise to the aorta. X-ray from a 20-month-old male with a Holmes heart characterized by the morphologic left ventricle that gave rise to a concordant aorta and an inverted outlet chamber denoted as OC in the picture in the left side that gave rise to a concordant pulmonary trunk. On the right side, same finding, the 20 years old woman with a Holmes heart. The echo in the subcostal window, it shows from a 10-month-old male with a finely trabeculated single morphologic left ventricle from which the pulmonary trunk originates. It is shown the aorta originates from the outlet chamber. The echocardiogram showing the aorta arising concordantly from the single left ventricle and the pulmonary trunk arising concordantly from the inverted outlet chamber. The main morphologic difference between the right ventricle and left and from the left ventricle are the following. The right ventricle, the presence of a moderator band, the presence of more than 3 papillary muscles, and the presence of coarse trabeculation. In trabeculation can also be seen in the left ventricle in case of pathologic non-compaction of the left ventricle. Normally, the right ventricle is a crescent shape when viewed from a parasternal short axis view. When the right ventricle is submitted to pressure or volume overload, the crescent shape changes to a D shape with subsequent septal flattening in echo. How the surgery evolves over the period of time for a functionally univentricular hearts. It all started from 1940s with the introduction of the Blalov-Taussig shunt, BT shunt. In 1952, the first description of a pulmonary artery bending, that is, was done. This both BT shunt and PA bending, this procedure aimed at a palliation of the patients with single ventricle hearts suffering from either shortage of the blood flow, which in turn causes cyanosis with a BT shunt, or if there is excess pulmonary blood flow, which is in turn causing the congestive heart failure symptom, treated with PA bending. Early surgical intervention were not part of a planned stage reconstruction, but it was that time considered rather than emergency measures. Next came the septation of the single ventricle. It was first tried in 1956. The first attempt at septation of a single ventricle at Mayo Clinic during surgery for a presumed CCTGA with PhD. The patient survived 6 months post-surgery. In 1970s, the revival of the septation concept was carried out by multiple groups. there are some rarer complications of septation for which it was aborted later. There is very high morbidity and mortality of this procedure. There is some very high incidence of heart block requiring permanent pacemaker. There is a chance of late residual VHD, atrioventricular valve incompetence requiring redo operation, high incidence of sudden death during septation procedure. Patient selection criteria for septation: aortic valve anatomy and function to be assessed. There is presence or absence of pulmonary or subaortic stenosis. The aortic valve, atrioventricular valve repair usually associated with increases mortality. Need for extracardiac conduit in case of separating the ventricle usually worsen the prognosis. In 1984, Ebert proposed a two-staged approach to ventricular septation. In the stage 1, small apical pouch, a small apical patch, and another patch between the atrioventricular and semilunar valves, if not PA bending done previously. In stage 2, 6 to 18 months later, it is associated with closure of the central portion of the ventricular septal defect. In 5 patients, they reported no heart block. Currently, the septation remains rarely used due to its high risk. Despite limited application, isolated long-term success report exists worldwide in last 3 decades. The next term, cavopulmonary shunt or Glenn shunt. Early experimental work on right ventricular exclusion in 1940s to 1950s. In 1949, Rothbard and Wagner from Chicago, they experimented on dogs by anastomosing the right atrial appendage to the pulmonary artery and ligating the main pulmonary artery, proving that the right ventricle could be bypassed. In 1950, the Carlo Carlone from Italy proposed superior vena cava to right pulmonary artery anastomosis, SBC to RPA, first tested in dogs with ligation of the azygos vein and SBC preatrial ligation. In 1956, Glenn and colleagues, Yale, conducted a large animal study with 6 long-term survivors. Physiological importance of the Glenn shunt. Glenn shunt increases the pulmonary blood flow significantly, which in turn higher the systemic arterial oxygen saturation. Unlike systemic to pulmonary artery shunt, it didn't increase the ventricular volume load. It demonstrated a feasibility of transpulmonary blood flow without a subpulmonary ventricles. In 1960s to 1970s, the clinical adoption and modification, the classic Glenn shunt were being widely used, especially in tricuspid atresia, but long-term sinuses recurrence was uncommon. The modification of the bidirectional flow, W.T. Heller and Azzolina modified this Glenn shunt to allow the SBC blood to flow into the both pulmonary arteries via an end-to-side SBC to PA anastomosis. This preserved the central pulmonary artery confluence, which is important, and it became the preferred palliation for functional univentricular hearts, that is modified BDG. Currently, the bidirectional superior cavopulmonary anastomosis is commonly referred as BDG, is the treatment of choice for palliation. Next came the FONTAN's operation, first complete physiological repair. The first successful repair of a tricuspid atresia performed by the FONTAN in 1968, which was reported in a paper at 1971. It was inspired by a prior experimental work showing that the right ventricle could be bypassed without any systemic venous hypertension. In his original procedure, which was reported in 1971, included a gland anastomosis, superior vena cava to pulmonary artery anastomosis, the right atrial appendage anastomosis to the RPA, right pulmonary artery, the aortic homograph valve conduit between the right atrium and pulmonary artery, additional homograph valve placed at inferior vena cava and right atrial junction, atrial septal defect closure, and pulmonary artery ligation. This was the paper published in 1971, Surgical Repair of Tricuspid Atresia by Fontan. Thus, it is clearly denoted that surgical repair of tricuspid atresia has been carried out in 3 patients. 2 of these operations have been successful. A new surgical procedure has been used which transmits the whole vena cava blood to the lungs, while only oxygenated blood returns to the left heart. The right atrium is in the way ventricularized to direct the inferior vena cava blood to the left lung. The right pulmonary artery receiving the superior vena cava blood through a cavopulmonary anastomosis. This technique depends on the size of the pulmonary arteries, which must be large enough at sufficiently low pressure to allow a cavopulmonary anastomosis. The indications for this procedure apply only to children sufficiently well developed. Younger children of those whose pulmonary arteries are too small should be treated by palliative surgical procedures. The main goal of this Fontan was to create a circulatory system in which the systemic blood enters the pulmonary circulation bypassing the right ventricle and thus places the systemic and pulmonary circulation in series driven by a single ventricle. The cardiac output is no longer determined by the heart but rather by the transpulmonary flow of blood. The direct connection of the pulmonary arteries to the right atrium became preferred. High failure rates and morbidity in early years, attempts were made to incorporate a small right ventricle into pulmonary circulation, which showed mixed results. The modification came in the form of use of valved conduits from 1970s to 1980s, use of valve conduits and right ventricular inclusion. Baumann in 1978 introduced the porcine valve conduits to improve the right ventricular function. Zorn in 1979 created a right atrium to right ventricular connection using autologous pericardium. Later studies debated whether incorporating a hypoplastic right ventricle was really beneficial. Key lessons learned in mid-1980s, the right atrium pumping function is not necessary. There is no need for valves in the Fontan pathway. Success depends on unobstructed pathway between the systemic veins and pulmonary arteries, preservation of the pulmonary vascular integrity, and an adequate systemic ventricular function. Total cavopulmonary connection TCPC by D. Leval in 1988 excluded most of the right atrium from the venous to pulmonary artery pathway. The components were end-to-side anastomosis of the superior vena cava to the right pulmonary artery, intra-atrial tunnel to direct the inferior vena cava blood to the pulmonary artery. The advantage of the TCPC was less turbulence flow, reduced energy loss, and lower risk of thrombosis in the anastomotic channels. There is reported as fewer arrhythmias, less atrial tissue under high pressure of the channel. Extracardiac TCPC from the late 1990s onwards uses a prosthetic or homograph conduit to connect the inferior vena cava to pulmonary artery. The advantages were it avoids the atrial suture lines and keeps atrial pressure as low as possible. Can sometimes be performed without the cardiopulmonary bypass. The disadvantage was conduit lacked growth potential, so surgery is delayed until the patient is large enough. Then came the staging Fontan operation. Refinement of a Fontan operation. The technical advancement in modified Fontan operation reduced overall mortality. However, throughout the 1980s, the morbidity and early mortality remained problematic. Challenges in early Fontan operations. The post-operative complication in early Fontan operation consisted the elevated central venous pressure, the tachycardia, the fluid sequestration in the pleural or peritoneal spaces, hypotension, unresponsive to volume administration. Limited improvement with inotropic agent, vasodilated, and external compression devices were observed. The ventricular adaptation issue, the post-Fontan circulation caused rapid removal of the chronic volume load. Myocardial mass degrades slowly, leading to high ventricular mass to volume ratio, increased wall thickness and reduced cavity size, impaired systolic and diastolic function. These factors for mortality was the older age and increased ventricular hypertrophy. Rationale for staged Fontan approach was proposed to reduce a single ventricle's volume work early. The aim was minimize the changes in the ventricular geometry and improve survival. Later on the evolution, the development of a staged Fontan approach occurred at late 1980s to early 1990s. The staged surgery investigated. Some used it selectively for high-risk patients, while others applied it universally. The goal was to reduce Fontan-related morbidity and mortality. Then came the Norwood's hemifontan procedures in 1989. The first step was towards total cavopulmonary connection. It redirected the SVC blood to return through the lungs before the single ventricle. The functionally equivalent to the bidirectional gland anastomosis. Difference from the gland is it maintained a natural right atrium SVC connection. It enlarged caval orifices closed with a removable patch. It eliminated systemic to pulmonary shunt and antegrade pulmonary artery flow. It augmented the pulmonary artery confluence with a homograph patch. It addressed the ventricular outflow tract obstruction and atrioventricular valve regurgitation. Then came the completion Fontan procedure as a staged procedure after hemifontan or after bidirectional gland anastomosis. Currently, the most surgeons prefer bidirectional gland over hemifontan as a first stage of staged correction. Incomplete Fontan operation. Concept of an incomplete Fontan operation was developed to address the challenges similar to those managed by staging the Fontan procedure. It aimed to allow the temporary systemic venous decompression and improve ventricular filling. The lax adjustable atrial septal defect approach, it introduced by the Lax and colleagues, uses an adjustable or snare controlled atrial septal defect. Initially, it applied in cases with an atretic right-sided atrioventricular connection, but later adapted to TCPC. Fenestrated Fontan approach, the most recent. The alternative techniques using a simple fenestration in the lateral atrial tunnel made. It was created using an aortic punch device, which is usually a 4 to 6 millimeter hole in the PTFE patch used in the Fontan. It facilitates the decompression of the venous pressure, the systemic venous pressure, and it reduces It reduced the post-operative completions of the FONTAN. Closure of the fenestration, the post-FONTAN cardiac catheterization assesses the hemodynamics of the patient. Then the closure performed using a catheter deployed device if hemodynamically remains stable during a balloon occlusion of the FONTAN. Observed hemodynamic changes during trial of occlusion, either in case of increased systemic venous pressure, increased systemic arterial oxygen saturation, slightly decreased cardiac output. Closure is avoided if the systemic venous pressure rises significantly or cardiac output decreases dramatically. Outcomes and benefits of a fenestration in FONTAN. It early reports showed that it reduces the operative mortality in very high risk patients. It is used widely across the surgical teams for all FONTAN patients due to reduced morbidity. It associated with fewer completion such, such as pleural effusion or ascites. So this much part I covered in the first part, sir. Then the next class I will cover the operative procedures, the recent updates, and the articles regarding the Fontan operation and Fontan circulation. I will detail. I'll cover in detail, sir. Thank you.
Okay, thank you, Rajdeep.
Thank you.
I'm afraid I will not be able to do much comments because I have no experience in treating single ventricle. Jairaj sir may be able to guide you guys little better. Sir, over to you, sir.
The few things, you know, a single ventricle or univentricular physiological, because really very often they are not single ventricles. Very often there is a dominant ventricle and there is a small outlet pouch which is actually connected to the main ventricle by a bulboventricular foramen. And in these
Yes.
cases, the aorta arises from one ventricle and the pulmonary artery arises from the outflow pouch. So, I mean, if you classify these things, I don't know why you mentioned DILV first. The first is tricuspid atresia. That's the most common we see. When there is a tricuspid valve is absent, so this AST has to be present. So the flow goes through the mitral valve into a morphologically left ventricle. And
Yes, sir.
because it's a combined ventricle, there's a good mixing in those. So the saturation, as you said, in these cases, maybe 80 to 85. That's only mild cyanosis. The cyanosis in those conditions depends on whether it's a pulmonary atresia or pulmonary stenosis. Even in that condition, tricuspid atresia,
Yes,
normal
sir.
pulmonary flow, they're not very much cyanosed, because they're only very mildly cyanosed. And tricuspid atresia, usually you said type 1, type 2. Type 1 with normally related arteries, but aorta and pulmonary artery. Type 2 with a transposition.
Yes.
And the cyanosis is much most severely seen in cases of tricuspid atresia with a transposition with pulmonary stenosis. Those are the ones with maximum cyanosis. Then the other thing you mentioned is DILV. From your presentation, I thought DILV is the most common. It's not actually. DILV probably comes as second to tricuspid atresia. In DILV, both the tricuspid and mitral valve opens into one ventricle, which is usually of a left ventricular morphology. Very rarely it can be double inlet right ventricle, in which case the morphology is of a right ventricle. That's an extremely rare. The other condition, commonly seen is a mitral atresia, where the whole output, from the right side goes into a single chamber, which is usually of a right ventricular morphology. The two things. Then you also mentioned the hypoplastic left heart syndrome also comes in that. Then atrioventricular canal defect, uh, opening into single ventricle. And the other thing you mentioned is a heterotaxy syndrome. What is heterotaxy syndrome?
Uh,
This was the final years I'm asking. Heterotaxy syndrome.
Sir, also known as situs ambiguous.
Very
It's
good.
a
Yeah,
it's a rare condition.
yeah.
Mm, there is the internal organs of the chest and abdomen are also uh, deranged.
Very good.
Uh,
In which the liver, the spleen, everything is central. Neither it's a dextro, situs solitus or inversus. Similarly, in the heart also. It also sometimes coincides with a left atrial or right atrial isomerism. What does that mean? Left atrial or right atrial isomerism. This is not exactly related to our topic, but general knowledge.
uh,
Left atrial isomerism means both the atria are of a left atrial morphology. You find out the atrial morphology from the type of the atrial appendage. The right atrial appendage, which is sessile, the left atrial appendage, very often the Brown described as a finger-like. So the left atrial isomerism or
comes under
bilateral bilateral left side is often associated with a polysplenia, multiple spleens. That's what the syndrome is. Right
yes
atrial isomerism, where both atria
presented.
have the asplenia syndrome. So these are the basic things to understand. Then you went on describing all the 1980s. That's not the correct thing. That's not the uh, ventricular division. Actually, everybody has given up. You said in 18, Mayo Clinic did it 1980s. The septation is almost given up. Nobody did. Because you decide when the patient is fit for a two ventricle correction or a single ventricle correction. From that premise, you go actually. So all univentricular heart cannot have a two ventricle correction. They can have only a single ventricular correction. And then I don't think you understood very much what a classic Glenn is and what are the complications of a classic Glenn. What exactly is classic Glenn? Not done nowadays at all.
Uh, the classic gland is the connecting the SBC directly to the RPA, right pulmonary artery.
Yeah. Yes, correct. That means you divide the superior vena cava, you
Yes.
divide the pulmonary artery and close off the proximal part of the pulmonary artery and enter the anastomosis of the superior vena cava to the right pulmonary artery. That's a classic gland. That has a lot of complications, including development of pulmonary arteriovenous fistula in the right lung and failed gland after some time. So those days
Yes.
there used to be uh, techniques how to treat a failed gland, all those things. So that's completely given up when the bidirectional gland came up. BDG. That's a classical operation, and you refer to uh, some of your seniors because initially they used to be done cardiopulmonary bypass, but now lot of people, especially in Narayana Hridayalaya, they published a book, an article on uh, by BDG uh, without cardiopulmonary bypass. What's the
Yes, sir.
ideal
Yes, sir.
age to do BDG?
Uh, Sir, uh, usually it should be done from actually the ideal age is it should be below the 3 years. Uh, it is early childhood. The BTG should be done after 5 years, after 5 to around 8 years
No, no,
age.
no, absolutely wrong actually. In the NH, the cutoff is age 3 months. You cannot do a BDG before 3 months because of the normal pulmonary vascular uh, disease. I mean, not the pulmonary high blood pressure because it doesn't regress soon after birth. So before 3 months, you cannot do a BDG. So if a patient is very cyanotic, I told you the conditions where the extreme cyanosis occurs, the procedure is today BT shunt. So the classic procedure in any of the single ventricle with severe cyanosis, less than 3 months, uh, modified balactoxic shunt is done. After 3 months, you can do BDG. And the Fontan, the Emmy Fontan, the classic Fontan, is all given up. Classic Fontan, and of course, you should have said something about the Ten Commandments and all that. Of course, you might say next time. What are the
Yes.
indications and contraindications of Fontan? Why do they do a hemi-Fontan which has been given up? So you read about that also. And now the final operation is always uh, pulmonary anastomosis, pulmonary connection. TCPC, total pulmonary connection, that whether it is should be intracardiac or extracardiac. Most people prefer extracardiac because the cardiac arrhythmias are much more common in intracardiac and it's always associated with a fenestration. So you refer to these things and tell us in the next class, what is the currently accepted thing and how to do uh, all these things, You right? Tell us about it. Original Fontaine. They used to do homograph valves for this originally SVC, the IVC, and then between the right atrial appendage and to the pulmonary artery. Then there's many modifications, Bjork modification, the Kreutzer modification, all those things are there. That's for your general knowledge, but most of those things are not done nowadays. So you have to know palliation, BBT shunt, BDG when the child is over 3 months. Then you delay the um, TCPC till a later date because you said the size of the child has to grow. So otherwise you have to change the conduit later on. So next time when you present, you say these details, how the TCPC is done. Some people used to say even without cardiopulmonary bypass, we can do. That's not true. So all those things you say. And finally, what exactly you mean by a failing or failed Fontan and what are the treatments for those? What are the complications? Protein losing, enteropathy, and all those things, the complications of these operations. You come prepared for that. You ask your seniors also, what is the current practice, Septation and all, nobody does nowadays. So you
Yes,
decide whether a patient is suitable for a two ventricle correction or not. If it's not suitable for a two ventricle correction, you always do a single ventricle correction. It's still
yes,
known as FONTAN, but actually procedure is TCPC. Okay.
yes, sir.
Okay.
Sure, sir. I will present it in next
Yeah.
class, sir, for
Yeah.
the stage.
Yeah.
He said, what is failing Fontan? What fails Fontan? What are the signs, the symptoms of a failed Fontan? All the things. Protein losing enteropathy,
Yes, sir.
edema, pleural effusion, ascites,
Sure, sir.
And,
Sure.
and also give us some this thing idea about NH experience
Yes, sir. Sure.
statistics.
and what is the standard procedure that we
Yeah,
follow here.
yeah,
In the exam they may ask you that actually. See, this is a very highly complex condition, and at your level there may not be too much of question, but in case they do, the one question they will ask you is what have you seen and what do they do in your institution. So that much you should know,
Okay, sir.
right? Okay.
Sure, sir.
Thank. Any other comments anybody wants to make? Okay. Thank you, sir.
thank you very much. Bye.
Thanks, Rajdeep.
Thank,
Uh,
thank
Thank
you, sir. Thank you so much.